There we go. Welcome, everyone. Thank you so much for joining us for today's webinar. We're so excited to welcome you to the title of this webinar is Dr. Peter Rowe discusses living well with orthostatic intolerance. My name is Emily Taylor. I'm the president and CEO of Solve M.E, and I'm so excited and humbled and thrilled. I got more adjectives, but I'll stop there to just say welcome to Dr. Peter Rowe, director of the Chronic Fatigue Clinic at Johns Hopkins Children's Center, and member of Solve ME's Research Advisory Council. I'm especially excited to welcome Dr. Rowe here today to talk about his new book, which if you haven't seen it already, it's fantastic. I read it over the weekend, highly helpful. But specifically, I wanted to flash back a little bit. In 2023, as our last year's Advocacy Week events in Washington, D.C. drew to a close, we actually had a wonderful event where we were able to honor Dr. Rowe for his work as a medical provider, a researcher, educator, and advocate for MECFS and our End Long Covid. These communities have benefited so much from your work, Dr. Rowe, and we were so pleased to be able to honor you with that award last year. And in addition to treating patients and conducting research, as if Dr. Rowe isn't busy enough, he also joined us to publicize our desperate need for treatments and cures as part of our How Long national public awareness campaign for long COVID. In October 2022, Solve conducted a satellite media tour to raise awareness about long COVID, MECFS, and other infection-associated chronic conditions. And Dr. Rowe represented the medical perspective on that tour, along with our board member and long COVID patient advocate, Cynthia Adenig. He was interviewed by 27 TV and radio stations across the US in a single day and brought all of that knowledge and experience to that amazing platform. So thank you again. So now, as if that wasn't an introduction enough, I'll get on with your amazing expertise. Dr. Rowe's clinical interests and research for the last 30 years have focused on identifying biological contributors to MECFS symptoms. His group was the first to describe the association of treatable orthostatic intolerance and MECFS, the with joint hypermobility and Ehlers-Danlos syndrome, and the impact of adverse biomechanical strain on MECFS symptoms and function. That was actually a really cool study on the sham leg raise trial, which I highly recommend is an excellent read for those who are not familiar with that study. And of course, the reason why we're here today, last month, his new book, Living Well with Orthostatic Intolerance, A Guide to Diagnosis and Treatment, was published by Johns Hopkins University Press. And we'll have a link to the book in the chat for those who are interested in looking into the book more. Just a quick note about this amazing work of literature. The proceeds of the book go to support MECFS clinic at JHH. So that's a really important reason to look into the book as well. Guided by decades of research and treating OI in patients. Today, Dr. Rowe will provide some illustrative case studies, help explain the disease and the symptoms, and answer as many of your questions as time allows. And we got a lot of questions in advance of this webinar. So with that, thank you so much for joining us, Dr. Rowe. I am just humbled and pleased that you're here. Why don't we dive right in? Tell us why orthostatic intolerance.
So this is it's a medical term. Orthostatic just means upright, and it's a group of conditions where people get symptomatic with either prolonged upright sitting, or more commonly with standing still and remaining upright. And so the symptoms are typically things like lightheadedness. Some people will actually develop fainting. They can get trouble thinking and concentrating. They can have problems with headaches when they're upright, blurry vision. And in all forms of orthostatic intolerance that we've encountered in the literature, there's a much higher prevalence of fatigue and intolerance of exercise. So those are the cardinal features of MECFS. And along with that, those are all thought to be symptoms due to lack of adequate blood flow getting to the brain. Then the brain responds to that by pouring out adrenaline or epinephrine and other similar substances called catecholamines. These are part of the stress response. And when they are really at a high level, you can get palpitations, chest pain, shortness of breath, sweating, and a variety of other symptoms. So it looks like people have about 20 things wrong with them, but it's all driven by the lack of adequate blood flow to the brain, and then the body's physiologic response to that. So that's orthostatic intolerance. There are several forms of it that are diagnosed by differences in what happens with blood pressure or heart rate. Some people get an escalation of heart rate, and that can be associated with something called postural tachycardia syndrome, or POTS. Others have a more classic plummeting of blood pressure after a period of upright posture, where they develop what we call neurally mediated or vasovagal syncope or hypotension. So blood pressure can drop. And then others we're finding can have big reductions in blood flow to the brain, even without heart rate or blood pressure changes. So they just show up as having orthostatic symptoms.
Wow. I mean, that is so much to take in. And so these symptoms are really interwoven into some of the presentations of these illnesses. Is that accurate to say?
Yeah, correct. And our working assumption when we see somebody new with chronic fatigue is that they almost certainly have some degree of orthostatic intolerance. We
Mhm.
find orthostatic intolerance in almost 100% of the adolescents with this illness, with MECFS, and others have found these reductions in brain blood flow in about 90% of the adults. It used to be thought that this was uncommon in the adults because people were only focusing on heart rate and blood pressure abnormalities. But if you look at brain blood flow, which is the more important thing, as my colleagues in the Netherlands have done, Frans Visser and Linda van Kampen have done some amazing studies looking at ultrasound measurements of blood flow to the brain. They find that 90% of the adults also have orthostatic intolerance.
Wow, wow. That's a huge figure. So just to help kind of as a layperson understand, what is the body supposed to do when you have these gravitational changes? And do we understand why folks with MECFS and other orthostatic intolerance symptoms don't respond that way?
So it's the last part of that is still being worked out. But
Hmm.
normally, for humans, we have to be able to tolerate upright posture for sitting, walking, teaching. Most occupations require a fair bit of standing. And so when we stand, there is, let's say you've got about a 5 or 6 liter blood volume total for the body. You dump about a half a liter to a full liter into the lower half of the body when you stand up, just from the effect of gravity.
Hmm.
So immediately there's less blood coming back to the heart, and the heart has therefore less getting to the brain. So the brain doesn't like that. We've got lots of complex sensors in the body to recognize, okay, we're not going to do well if we're not getting gasoline to the engine.
Hmm.
Let's find a way to get more blood back up from the legs. So the autonomic nervous system, and autonomic is just a fancier term for this is the automatic part of the body. You don't have to think about it. You don't have to cause it to do anything. It's a reflex response. And the reflex response to not getting enough blood up to the brain is to send a message out through the spinal cord and the nerves. They wrap around all of the blood vessels and release norepinephrine to make the vessels constrict. Once the vessels squeeze, that brings the blood back up, or much of it back up to the heart and to the brain. And then things quiet down. The stress response settles. In people who have orthostatic intolerance, there are multiple reasons why they might not have that system working efficiently. But a big one is that they pool an excessive amount of blood in the lower half of the body. Some of that is because their vessels are stretchy, especially if they have things like joint hypermobility and increased flexibility, and a syndrome called Ehlers-Danlos syndrome, which is the most extreme form of joint hypermobility. So their vessels probably aren't squeezing adequately. And in our studies, 60% of the patients we see, at least in the adolescent clinic, have some form of joint hypermobility that they've had since birth. Why they tend to start getting sick in adolescence is
Hmm.
unclear, but it might be that the joint hypermobility is a predisposing factor, and then you need another hit, like, say, COVID or Epstein-Barr virus, to trigger the orthostatic intolerance. But in answer to your question, we don't really know why this is occurring after infections. We don't know all of the precise mechanisms. The good news is we don't have to know that to be able to try the treatments. And we feel that the orthostatic intolerance component is the most treatable part of just about everybody with MECFS and by extension, those who have post-pandemic long COVID that's fairly impairing and meets the criteria for MECFS.
Dr. You got right into my next question. My follow-up question is going to be, I know when my mother was first struggling with some of these symptoms, we learned very quickly that if she stood up too fast, that there would be either dizziness, lightheadedness, some blurred vision, or sometimes even loss of consciousness.
Yeah.
So we started with a step graded system to stand up more slowly, where she would go, from a seated to a seated more upright, from slightly more seated to going up, and then we would support her as she went up. That's just how we adapted to it. Do you have any other sort of suggestions, maybe like seating positions or other recommendations for people who are experiencing orthostatic intolerance? How can you sort of mitigate those symptoms in the day-to-day when you're just kind of moving around as best you can in your home or your day-to-day life?
Yeah, those are all really sensible ways to respond to too much of a drop in blood pressure or too much of a drop in blood flow to the brain. So getting up gradually, making sure you're clenching your muscles to get the blood moving around. And some people will sit there and, do this with their hands or do heel lifts like you're taught to do if you're on a plane to avoid a clot. So something to get the blood flowing and the muscles pumping the blood. And then others have found out, and this came from a study at the Vanderbilt University Autonomic Clinic, that if you guzzle a good 6 to 8 ounces of water before you get up, that helps maintain your blood pressure a bit better. The other thing we've noticed is that many times we can tell the patients likely have orthostatic intolerance because the kids will sit in clinic with their knees up to their chest like this. And there are a number of postural counter maneuvers like this that reduce the amount of blood that's pooling. Many people stand with their legs crossed over like a cocktail party stance. People often prefer shoes that have a heel because that engages the calf muscles and pushes the blood up. Have to shift their weight and move around and are constantly fidgeting. So people often adopt these postures not necessarily knowing why, but they know that they feel better in that situation. The knees up to the chest stops the legs from being down and allowing blood to pool. And then when you bring your knee up like this, your leg muscles have squeezed the blood out, and you're also squeezing some of the blood that pools in the abdominal cavity. And one of the funny things that happens in our clinic is when we tell the teenagers, this is a good position for you to sit in, they typically glare over at one of the parents and say, see, I told you.
And it's more comfortable, right?
Yeah, there's always been some kind of battle about, how you sit properly at the dinner table. But this is why they're doing it. They're not being oppositional or willfully disobedient. And some of our patients, when they're upright sitting, if they're driving, they'll put their left leg up on the seat to, again, avoid too much dependent pooling of blood. So there are a lot of things people can have figured out. In the early days of our studies, in the early 1990s, we had a number of patients who had MECFS. And at that time, everybody thought, we don't know what else we should be doing, so let's at least eat a healthy diet. Well, the healthy diet recommendation was that everybody should cut back on sodium. That was particularly bad for people who have blood pressures in the lowest quartile of the blood pressure distribution. So in the beginning, one of the things that helped was just to add more dietary salt to the diet, eat saltier foods like pickles and salsa and soups. And for some of the people who've been too restrictive on their sodium intake, that was enough to get them more functional again. So the sodium helps draw fluid into the blood vessels. So when you stand, you've got a bit more left in the heart to pump to the brain than you would if you were dehydrated.
Wow, so salt intake good in these cases, not necessarily bad, like we're kind of often told. That's fascinating.
Yeah.
What about, oh, sorry, go ahead.
I was just going to say, in some ways, the idea that everybody should be treated exactly the same way is silly in biology. So the advice came from an era when we didn't really have any good medicines for high blood pressure. And
Mm-hmm.
that can lead to strokes and heart attacks. So way back in the 1940s, there was an editorial in the New England Journal of Medicine that was entitled something like "Hypotension is the ideal blood pressure." Well, I can understand why they might have said that in 1940. They didn't have any good antihypertensive drugs, but it makes no sense to ignore low blood pressure these days. And if you take people who have been on a regular intake of sodium and you enforce an extremely low sodium diet, guess what? You get fatigue, brain fog, and exercise intolerance. So you can recreate many of the key features of MECFS just with that.
Wow. So just my question earlier was about with again thinking about my family's personal journey. We tried salt loading, and then we also were recommended to try electrolytes along with the fluid loading. So how do the electrolytes those are things like the liquid IV or Pedialyte or some of those other things that kind of add electrolytes to the fluid. What's the benefit of that, or is there a benefit to that?
So I think the main benefit is just the amount of sodium that are in those products.
Mm-hmm.
It's just another way of getting sodium into the body that helps hold the fluid within the bloodstream. If you just drank water all day, you'd pee it out pretty promptly.
Mm-hmm.
Eating a lot of sodium in the diet or having it in the electrolyte drinks or salt tablets is a way of keeping that fluid there. Um, I mentioned earlier that one of the key factors that leads to orthostatic intolerance is this tendency for people to have excessive blood pooling in the lower half of the body. But for reasons that are unclear, many patients with orthostatic intolerance also can't maintain their blood volume properly. They're about 10 to 15% low. And the best studies on MECFS in that on that topic really came from Nancy Klimas's group in Florida, where they showed that there was, when you did blood volume measurements, people were sort of too low. And we don't understand why the body doesn't correct that, but that seems to be a consistent feature. So low blood volume, uh, uh, more pooling of blood, so you get this excessive reduction in the return of blood to the heart, and then you get the catecholamine over response, which in some ways is an appropriate physiologic response to not getting enough blood to flow to the brain. But all of the adrenaline that's released is going to cause other symptoms.
Absolutely. Well, I'm so glad you brought up some of the work that because my next question for you is how in your work, when you were working kind of on OI specifically, orthostatic intolerance, how did the MECFS connection come in, or how did you what sort of led you down the road to start looking at MECFS as a function of OI or vice versa?
I actually brought a couple of slides, so let me
Oh,
show.
wonderful. I
I,
love slides.
I think it's a fun story. We I'm going to go back up a bit. This is just our team at Johns Hopkins and the Children's Center. Um, we've put this book out to um, with the intention that the proceeds would go to supporting the salaries in our group. For many years, it was just me here, and then 4 years ago, I was able to bring on Renee Swope, who's a nurse with 3 kids who have MECFS and POTS.
Mhm.
She'd been a school nurse, so she's very invested in the topic. Her daughter Megan joined us as a research coordinator and assistant. Dr. Broussard's an adolescent medicine specialist. And then Dr. Zola, who's in the polka dots, was running the long COVID clinic for the adults at Hopkins, and we were able to attract her because we don't have an adult MECFS clinic at Hopkins, so we were continuing to follow our adolescent patients well into adult life, and so she's helping me with the care of those folks. But the story began back in the early 90s when I was running a diagnostic clinic, and we noticed that the kids coming in with chronic fatigue or chronic fatigue syndrome looked very much like our fainters. So they were getting symptomatic when they were standing in line and when they were at a reception or in the choir or in the marching band. And one of the jokes we tell our trainees is that if you've got an adolescent who can't go to the shopping mall and stay there for very long, you've got a medical problem until proven otherwise. And our patients do not like going to the shopping mall because it brings on their orthostatic intolerance. Same thing if they go to a museum and they're walking really slowly. So we
Mhm.
decided, we thought, gee, they're getting sick in the same situations as people who have recurrent fainting. And around the late 80s is when tilt table testing came into vogue as a way of measuring what happened to blood pressure in the fainters. And this is a motorized table that comes up. It's got a footboard for weight bearing, and you just watch what happens to their blood pressure. So I said, well, I wonder if this is triggering the fatigue in those with chronic fatigue syndrome. And so I approached Hugh Calkins, who's shown here. He runs our tilt lab at Hopkins. Jean Kahn is a pediatric cardiologist, and her fellow Isam Bohalega helped us with this study. And we took 7 consecutive adolescents with chronic fatigue or chronic fatigue syndrome, and all of them had tremendous drops in blood pressure with symptom provocation during the tilt test. So then we said, okay, let's try and recruit a group of people with confirmed MECFS, or CFS as it was called back then. And we were lucky enough to meet Ellie Brocious. Many of you will know Ellie's name. She is the coordinator of the support group for MECFS in Northern Virginia. And you might wonder, well, why were you going down to Virginia? Couldn't you get people from Baltimore to come into Hopkins for this research study? And we had approached the local support groups, but their experience with Johns Hopkins before that point was that everybody got sent to the psychiatrists. So they
Mm.
wanted nothing to do with Hopkins. So we were very lucky because Ellie ran the support group in Northern Virginia, and Katie Lucas, now Katie McDonald, ran the one in down in Richmond, and they provided, together with Susan Chamblin, who was out in Hagerstown, all of the patients for our next study. But one of the things they encouraged us, as we were seeing so many people develop hypotension on the tilt table, is, you're going to need to treat people. You need to put together a brochure showing them how to do this. So that brochure became this general information guide. Some people have downloaded this from Dysautonomia International, where they have it posted, but we've been giving it out to anyone who calls ever since the early 1990s. And many of their suggestions were incorporated into this book, or into this brochure. And then this led us to say, well, we need to get this information out to the rest of the public, especially in the post-COVID era where so many more people are being diagnosed.
Mhm.
So that led to the book coming out. And just to give you a sense of what's in there, we talk about the basics of orthostatic intolerance. Really, the question you just asked me, Emily. How does this develop? We describe the different symptoms.
Mhm.
We look at some of the things that can cause it, like it's often common after infection. And then there's a big section on treatment that we can get to later that talks about not just the treatment of the orthostatic intolerance per se, but the many different conditions that can be coexisting with it. And then we have suggestions on how to find a higher sodium diet. And then we've learned a lot about using the different medications for orthostatic intolerance. So, for example, fludrocortisone or Florinef is the main one that helps hang on to sodium in the body, and that helps treat blood volume. Atenolol is one of the many beta blockers you can use that sort of blocks the effect of the high levels of epinephrine and norepinephrine. We use a lot of vasoconstrictor drugs that make the vessels constrict better if they're stretched out and pooling too much blood. So the stimulant medicines, like the ones we use for attention deficit disorder, are very helpful. Midodrine is a non-stimulant. Some of the drugs used for anxiety and depression also do a bit of that to the vessels. And then there are a variety that are a little bit harder to classify. Pyridostigmine bromide is a drug that kind of balances the different arms of the autonomic nervous system. Desmopressin helps the body hang on to fluid. We use that drug in children with bedwetting because it reduces the amount of urine that you form at night. Clonidine is an older antihypertensive drug that for some reason improves blood volume in this group of patients. And then the newest one is ivabradine, which is used a lot if you have a heart rate above 100. It's very good at controlling heart rate.
Oh,
So
wow.
Those are a couple of that's sort of the outline of the book. And then in chapter 7, we list a number of cases. I wanted people to get a sense of, is this an easy process? It often requires a number of attempts to find the right medicine for that person. And so this is not a one size fits all kind of problem, orthostatic intolerance. This chapter illustrates a number of people who did improve, partly because I don't want people to be pessimistic about the potential to improve, but also describes a couple of the tougher, more challenging cases that we've seen to illustrate some of the other comorbid or coexisting problems. It's not a super long book, as you've seen. We wanted it to be really practical and useful for patients, but it's also got information in there about things that other physicians and healthcare providers could use.
Wow, so that is so fascinating, and I have to stress again, I thought I knew a lot about this topic until I read the book, and then I felt like I already took away things that we could apply in my family's day to day. So
Great.
you mentioned how you need to kind of tailor the treatment to the individual, and as you were describing certain of those drugs, for example, the drugs that constrict vessels, that seems like it might be really helpful for the folks with those stretchy vessels you mentioned earlier that were stretching too much because of the connectivity potential issues and kind of how that was impacting. So how do you go about kind of as from a conversation with a physician, or how do you go about matching the right drug to the right person? Like what does that conversation look like?
So sometimes we'll get the question, what is the best drug to try? And my answer is always, it depends. And it depends on the patient. You've got to individualize this. There are people who approach orthostatic intolerance and say, look, everybody with POTS needs to get a beta blocker as the first line drug. And then the second line would be midodrine. And then beyond that, it's anybody's guess. I think we can take into account better information from each patient. So for example, we had a young boy who was very intolerant of upright posture, but he kept a salt shaker at his bedstand. He'd put salt on his hand and lick the salt. Well, I thought that was giving us a huge clue. He's got a very high salt appetite. Let's give him fludrocortisone to help him hang on to that sodium. And that ended up being a really good answer for him. For some of the girls who can often get way worse menstrual cramping at the time of their periods and be more orthostatically intolerant, much more lightheaded and much more fatigued, the first line drug might be a birth control pill that gets at both problems. It reduces the cramps and improves their blood volume. If somebody has a lot of hypermobility of the joints, we often will select a stimulant or midodrine first, just for the reasons you mentioned. And clonidine and guanfacine are interesting drugs because a certain proportion of our patients have excessive sweating. The medical term for that is hyperhidrosis. Turns out that clonidine and guanfacine can be very good at night for blocking the sweating and building up the blood volume. And both of them are used for improving brain fog in kids with ADHD. So we often try to find a medicine that gets more than two of the problems addressed. But it's the summary statement or summary response to your question is really you really have to do a lot of trial and error. And even when we think we've got a brilliant hypothesis about what's going to work for this patient, it might not work. So you've got to have a backup plan always.
Absolutely. And especially kind of keeping in mind the sensitivity of people with MECFS to medications, what does that kind of onboarding, offboarding look like? You kind of step up, step down, and then how long of a period does it take for these medications to kind of acclimate as you step up? So like what would you and I don't want to go through specific recommendations, but generally what would you say in terms of as you explore some of these treatments?
So we learned this from the patient advocates, Ellie and Katie, when they were bringing their support group members up to be part of our first study. They said, you got to start low and increase gradually. Mm-hmm. And so with Florinef, for example, the old advice was start people on a full tablet. Well, we knew that a lot of our patients who have these medication sensitivities were not going to follow that advice. So we just put in the guidelines, you can start with a quarter of a pill, make sure you tolerate that for a few days to a week, and then go up by in quarter pill increments. And you can do that with virtually all of these medicines. Start
Mhm.
very low, make sure the person tolerates it, they're not getting side effects, and then go up gradually, and you'll eventually usually reach the standard top dose.
And so then if the drug is maybe not working and maybe okay, this would maybe when you try something else, how would you recommend tapering down again in the same process?
Yeah, so it's probably a bit different for each drug. And back to your question, it's the difference is probably the amount of time that you need to stay on the medication is different for each drug. So for
Mm.
Florinef, as long as you're not having side effects, we'll usually keep people on that for a good month to see what happens to building up their blood volume. Do they feel better in a month? And if they do, we might consider a slight increase in the dose or just leave them on that medicine for a bit longer. With the stimulants, they work immediately. So once you get up to an adequate dose, if there's nothing happening, you're probably going to stop that. You don't have to wean that one down because the drug's only in the system for 8 to 12 hours, and then you've gotten rid of it. So for the stimulants, you don't need a long weaning process. Clonidine, on the other hand, is a drug where if you do stop it abruptly, you can get a reflex or rebound increase in blood pressure. So you got to be careful about going down on that one slowly. So for each of these medicines, we've got tips on how to ramp them up and then come down safely.
And I'll just emphasize again, if you haven't checked out the book, all of this is in there in a lot of great detail. So it's definitely worth digging into if you're interested or your medical team is interested in any of these medications for your treatment. So with that, I'm gonna shift to something a little bit more controversial. I hope you'll forgive me. But sometimes we read in a lot of the POTS literature, the postural orthostatic tachycardia syndrome literature, that exercise is a way to get better for people with that set of symptoms. What do you recommend about activity and exercise in the book? And do you have any insights that you'd like to share about how we can reconcile some of those folks who do improve with exercise, and yet sometimes people, and a lot of times in MECFS, get worse with exercise. So how do we kind of find that balance?
Yeah, I think it's a really important area for people to understand because the goal of getting better is to increase your activity level to the point where you used to be at, right? But
Mhm.
getting there is the challenge. And I think in some ways the material that was out there in the early 1990s, which was that, these are just lazy patients who need to be more active, and put them through a graded exercise program and give them cognitive behavioral therapy to get rid of their erroneous thinking about the illness, and they'll be fine, they'll be cured. Well, that was complete nonsense then, and it remains nonsense today. Our experience with people who have POTS without MECFS is that there are occasional patients at the very mild end of the spectrum who mainly, and who have been inactive, who mainly need increased salt and fluids to support their circulation, and then gradual increases in activity. But the vast majority of people will get worse with that. And so we want people to, yes, be more active. That's the entire goal of the treatment, but we have to provide the support to their circulation that allows that. We never have had to cajole people to get more active once they feel better, right? Like,
Exactly.
I'll give you an example of one of my patients from the 1990s who got better and came in 6 months afterwards to follow up. And I asked him, how are you doing? And he said, well, I still feel the same. And his mother whacked him in the shoulder and said, Ben, tell him what you were doing yesterday. This was a kid who'd been housebound. He said, well, we went out and played 18 holes of golf. And then we came back and did some swimming. And then we shot some hoops. And then we went to the movies in the evening. He said, but I still feel tired. So this is a kid who had taken a very healthy response to improvement and expanded what he did rather than baby himself so that he didn't have any symptoms. And that's what I mean by patients who feel better will do more without our prompting.
I love
But
that.
but we have to support their circulation. I think I had another slide. Let me see if I can find that one. Yeah, this one gets at this point. This was a 22-year-old from the Baltimore area She had developed MECFS after a cytomegalovirus or CMV infection as a teenager. It was a mononucleosis episode. And by the time I saw her, she had orthostatic intolerance that had been diagnosed by others. She was pretty flexible. She had hypothyroidism, but treating that didn't improve her fatigue. She was a bit depressed because she was just frustrated that she wasn't active. She had migraines and she was tight on those range of motion exercises you were referring to at the beginning. So we stood her up. We use a passive standing test in the clinic. This is where the person is lying flat for 5 minutes, then they stand leaning against the wall for 10, and we're looking for, do they get at 17 a 40 beat increase in heart rate, which would diagnose them with POTS? Well, she had a 38 beat increase, but much more important than the number is the fact that we could reproduce most of her main symptoms. So she was lightheaded, she was hot, she was tired, she would get headaches, and she had purple limbs, which is the medical term for that is acrocyanosis. So we tried her on a bunch of things, both for her headaches and for her orthostatic intolerance. And you can see the long list of the remedies that are mentioned in the book that didn't work for her. By the time she was 22, we'd been working on her for 5 years. She would come into the clinic and her heart rate would be somewhere between 104 and 140, just sitting there, really quite extraordinary. And she had read that POTS literature that you were referring to. She felt compelled to try to exercise, and she tried to frequently, but every time she did, within 2 minutes, her heart rate was up to 180. That's like Michael Phelps in a full sprint. That was way higher than it should have been, and it would provoke a 2-day migraine. So we said to her, Samantha, you've got to stop trying to exercise because it's making you worse. It's giving her too much post-exertional malaise. Then along came Ivabradine, this newer drug that was approved for treating high heart rates in people with heart failure. So it only works on the heart rate, not on blood pressure. So here she is on no drug, resting heart rate's 115. She spikes up to 180 within 2 minutes and gets a 2-day headache. As we increased her dose gradually, and on the left-hand column, by the time we were on 5 milligrams twice a day, she now only went to 155 and could exercise without a headache. Ideal dose for her turned out to be 10 milligrams twice a day. And then she would go for 40 minutes on the elliptical with a heart rate about where a healthy person's ought to be, around 130. Again, no headache. So she was able to get quite fit. And at this time, she was working as an occupational therapist out in Phoenix, actually on the proning unit for COVID in the early part of the pandemic. She took a vacation and she went north of Phoenix to Sedona, to this beautiful area for hiking, and she could do 10 miles in a day. So, part of the reason I love this picture that she sent is that some of the more behaviorally oriented people in the 1990s used to say, well, again, all you need to do is get these people fit, they'll be cured. Well, so I think anyone who can do 10 miles in a day is fit. But the problem was that Ivabradine's a newer drug. The insurance company wants it reauthorized every year, even though she's doing great on it. And so she goes without it for 2 weeks. Guess what happens? She gets tired, lightheaded, and brain fog all back again. So we are managing her symptoms. We didn't cure her of anything, right? But she's able to get the benefits of activity on her orthostatic intolerance, which involves anytime you're able to exercise, you can make more blood. Well, if you're deficient in blood volume, that's going to eventually help you. So that's the perspective I like to put, Emily, on the issue of exercise. But it's very important that we pick small amounts of activity initially, make sure that we are not provoking post-exertional worsening, because then you might have 1 day of activity and 3 days of recovery. Well, much better to inch along and very gradually bump up your exercise volume or your activity volume. It doesn't even have to be formal exercise. But I don't want people feeling guilty for not exercising if they feel unwell. And so this notion that you could create a strategy that everybody should follow with exercise, to me, is insane.
So it really is individualized to the patient. I love that there was the example in the book of the young woman with the 30 seconds a day on the reclining exercise bike. I thought that example was really powerful because it showed her perseverance. It showed how dedicated she was, and yet mindful of her symptoms and really keeping those increments so tiny because she was, making sure she stayed within that energy envelope. So I love that presentation. I love that description, and I love the good stories that come out of it in your book. So with that, I know we're about out of time for this portion of the conversation. We're
Yeah.
going to turn it over to some of the questions we've received
Okay.
in advance. If that's okay, unless there's actually, before we turn it over, is there anything else, Dr. Rowe, you'd like to share before we go into the questions and answers?
Just that in the book we talk, and in our clinic we talk a lot about the non-random coexisting conditions that occur in this illness. People say, well, why do you have so many diagnoses? Well, it's not accidental. If you're hypermobile, you're more likely to have temporomandibular joint dysfunction. You're more likely to have orthostatic intolerance. Paradoxically, you're more likely to have areas of movement restriction. So like thoracic outlet syndrome, a lot of our patients, as we're studying currently, have a lot of arm fatigue and lightheadedness and other symptoms when their arms are overhead. Classic position for most young women is when they're shampooing their hair, provided they have a little bit more on top than I have. But we find that that's another treatable component, but it needs to be addressed by the physical therapist because you're not going to fix it with these orthostatic intolerance medicines. But it's this appreciation that many things can go into aggravating the orthostatic intolerance. And another thing that is being uncovered more and more lately, getting a lot more attention, is vascular compression problems, where people can have compression of veins in certain parts of the body that lead to less blood coming back up to the heart. And so there's a lot of interest in that among interventional radiologists who can treat those problems. So it's really understanding the complexity.
Fantastic. I think that there's certainly no shortage of complexity in these areas of health. That's for sure. So one of the questions, and I'm going to try to consolidate two or three questions in one.
Okay.
So one of the questions talks about OI and hypertension and other potential complexities along with MECFS. So I guess I'll summarize these questions together by saying when you have OI, orthostatic intolerance, and other chronic illnesses, how do you fit your OI treatment into your other health treatments like your MECFS or your POTS or your other health treatments that you might also be managing at the same time?
Yeah, so that's, I think, the art of treating people with these disorders. But just to take your example of high blood pressure, most people, younger people, let's say under the age of 40 with MECFS do not have high blood pressure. They tend to be in the lower part of the normal range. But people who have orthostatic hypotension also have supine hypertension. So these are people who, when they're lying flat, they're hypertensive, their blood pressure really high. When they stand up, it plummets like a stone. So they need something to take when they're upright. But if they misjudge it and they lie down, it makes their supine hypertension worse. So those patients need different sorts of things than, say, an 18-year-old with POTS. Some patients can develop a hypertensive response to our 10-minute passive standing test. Those patients probably are getting increases in blood pressure because they've got so much epinephrine and norepinephrine floating around in the bloodstream that it's driving up blood pressure. And so you've got to be aware of exactly what each patient is going through and what their baseline pressures are.
Great question. Wow, that's a lot to unpack there. So what does that mean for kind of we're talking about the treatment side. What does that mean for the diagnostic side then? If you're trying to peel those different pieces, would you recommend, especially for things that are easy to try, like salt loading or fluid intake, would you recommend just trying them to see if as part of your diagnostic journey, or would you recommend getting the diagnosis first before you begin treatment?
I think it's probably important to do the standing test, which can be done in any physician's office, 5 minutes supine, 10 minutes upright, a couple more minutes flat again. So within 20 minutes, you've got somebody seeing that, oh, this person can't stand up without getting lots of symptoms. I think it's an incredibly validating easy, inexpensive test to do. If you go in and people are only looking for heart rate changes for
Mhm.
POTS, and you've already started on the treatment, right? Your heart rate increment might not meet between supine and standing might not meet the POTS criteria. And if people are very rigid about who they're going to treat, it's only if you've got a 40 beat increase in heart rate if you're under 20, or a 30 beat increase if you're over 20. If
Oh,
they're really rigid about who they're going to treat, that uh, salt loading and fluid loading before you get to the diagnostic test means that you've excluded yourself from something that might be a helpful treatment. My hope would be that more physicians pay attention to orthostatic symptoms, not just the heart rate and blood pressure changes. My colleagues in the Netherlands have shown that there is a huge proportion of adults with orthostatic intolerance who can't raise their heart rate adequately. They have a thing that's called chronotropic incompetence, meaning they don't get the heart rate increment that a healthy person would to the reduction in blood return to the heart. So if you're looking for POTS in those guys, you'll never find it. They can't develop POTS. They have lots of symptoms though. So you really have to pay attention to the symptoms.
absolutely. Wow. So I want to dive into that more, but there are so many questions. So I'm going to step away and move on to the next topic. This one is another combination of a couple questions. I've got a couple questions about that adrenaline surge that you spoke about earlier, and how do you kind of prevent, mitigate, or manage when your body is trying to keep up with whatever symptoms you're experiencing, and you get that adrenaline surge. I mean, I know for my mother, for example, it comes with a lot of shaking. It comes with difficulty walking, difficulty thinking, difficulty speaking. So all of that, what would you recommend if you're already experiencing, you're already past the point where you're getting the adrenaline surge? What do you do then?
So I think the basics really still count, extra salt and fluids. Some of the people, when epinephrine is surging, people will get a hot flash. And so we find that if the epinephrine is the cause of that hot flash, some of the beta blocker drugs that block the binding of epinephrine to the tissues, that can be really helpful. So that's a situation where you're matching the hot flash report with a drug that'll block it. So that can be one of the helpful things. Some people, when they lie down at night, they're mobilizing a lot of blood from their feet up to the central part of the circulation, and they start getting sort of jazzed up. And one of the tricks I've learned from Alan Posinki, who's an MECFS and Ehlers-Danlos internist in the Washington suburbs, is to try them on low doses of propranolol, which is a short-acting beta blocker, just at bedtime. And that can help improve the quality of the sleep in those patients because they're not so jazzed up that they're easily aroused from the slumber. And it calms their heart rate down, so they probably aren't awakening as much. So there are a variety of different techniques that you can try for that adrenaline surge.
Got it. That's really helpful. And then a follow-up question to the adrenaline surge. This is sort of a sub question. Is there any relationship, or could there be a relationship to a lot of the literature we've read about microclotting in MECFS and long COVID and other infection-associated chronic conditions? Could that be part of the puzzle?
It's hard to know because pre-COVID, before that hypothesis emerged, none of our patients had developed abnormal clotting,
Mm-hmm.
right? We didn't typically see thrombus formation, even though all this blood is pooling in the lower half of the body and is kind of moving sluggishly through the circulation, which should be a predisposing factor for developing blood clots. And yet that was not what we were seeing.
Oh,
Uh, Back in the 1990s, there were a few papers on people trying heparin as a blood thinner for MECFS. I don't think that literature really went too far. But it's an interesting paradox to me that we can have a situation like orthostatic intolerance that's almost universal in MECFS, and yet we're not identifying clinically these situations with clotting. With the microclot story, I would have thought that if there was a flexible clot that sort of plugs up the microcirculation, we would normally see that in terms of skin petechiae, little dots in the skin. So I've been puzzled as to why that is not a feature that we see. So I think we need a lot more science to try and unravel what might be going on. I know that different groups have identified microclots, but I'm puzzled by the juxtaposition of that and the orthostatic intolerance. We still don't use any drugs that work on the clotting cascade, and we still see people getting better.
Huh, interesting. So in that regards, do blood thinners impact orthostatic intolerance? Is that that blood volume issue?
I think what would be needed is for people who are treating folks with those blood thinners and anticoagulants to look at whether it makes any difference to their orthostatic responses, to their whether they get symptoms when they're upright. I haven't seen those studies if they've been done.
Okay, well, I'd be very curious to read about that as well. A couple last questions. This is about 5 questions tumbled into one. We haven't talked about MCAS, mast cell activation syndrome, at all. So, that's been linked to reduced blood flow in the brain and some other factors as well. What is your take on mast cell activation syndrome? Is there a place in the OI space that overlaps?
So we think so, and the more we look for it and try the treatments that are used for MCAS, the more we're finding successes in people where we were sort of striking out before. One of the things that had been recognized pre-pandemic and before mast cell activation syndrome had even been described was that many of our patients had lots of allergies. And we had noticed with our colleague Kevin Kelly at the Children's Hospital of Philadelphia, he was here at Hopkins for a while, that about a third of our patients with MECFS had milk protein intolerance. And it wasn't a true allergy to milk. It wasn't an immediate reaction. It was delayed by about 4 hours. And we recognize it because they get upper abdominal or epigastric pain, reflux, and an appetite disturbance where they feel full easily, early satiety. Some of them have recurring mouth sores inside the mouth. If we take them off their milk protein, those symptoms generally get better. And we've written a paper about this because we thought it's another easy treatable component that contributes to the illness. Probably most of those patients that we said had milk protein intolerance would meet criteria these days for mast cell activation syndrome.
Wow.
And so mast cell activation syndrome can be the driving force for POTS. Again, it sort of emphasizes that you've got to find out what for this patient is perpetuating the symptoms. So you might pick something like oral cromolyn to calm down the mast cell membrane rather than a blood pressure drug to treat them as a first-line agent. But we find that the treatments for these patients who typically have multiple medicines and multiple foods that they don't tolerate, have flushing of their skin. They often look very red. They can have itching and hives. They can have lots of other symptoms that overlap almost completely with MECFS. So they can be tough to differentiate, but treating their mast cell activation syndrome with antihistamines, famotidine, and other things that stabilize the mast cell membrane can be incredibly transformative for patients. Larry Afrin, who's been a leading clinician educating us on this topic, Larry had hypothesized way in the beginning of the pandemic that mast cell activation that's been undiagnosed and untreated sets the stage when the SARS-CoV-2 infection begins for triggering the exuberant inflammatory response to COVID and to perpetuating the symptoms, creating some of the patients with long COVID. I think that hypothesis fits with what we are seeing. Not in everybody, but that's, again, not to be expected that there's a one-size-fits-all in this illness. But it's really important for us to pay attention to anyone with a lot of cutaneous redness and multiple things that they react to. So the mast cell piece is a very important one to study and to use for treatment.
That is so fascinating. And then just for those who may not be familiar, I'm just seeing a couple questions pop up in the chat. For those who are not familiar, what is a mast cell? Because we just talked a lot about them, but that not everyone's familiar with that term.
You know, I love it when people put the brakes on and make me go back to the basics. So the mast cells are white blood cells, and they're made in the bone marrow. But unlike neutrophils or lymphocytes or monocytes or eosinophils, you've all seen them on your CBC differential, right? On those reports. Those are the ones that float around in the bloodstream. They're released from the bone marrow into the bloodstream, and they stay there or they migrate to some of the tissues, but you can measure them. The mast cells migrate very rapidly out to the tissues, and they sit at the interface between us and the external environment. So they're plentiful in the skin, along the airway, along the GI tract. So everywhere we have encounters with the outside world, and they're important at the interface between the nerves and the blood vessels, all of which relates to orthostatic intolerance. And their job is they're full of little granules that are full of histamine and other biologically active substances. When they see an intruder coming into the skin, they dump out their contents, and that helps with the normal host response to infection. So they're activated by different infections. What's puzzling is, why do some people have their mast cells stay activated rather than calm down when the threat from an infectious agent is gone?
And that sort of ties into that whole immunology piece, which ties into all of these other pieces. They all kind of hook together.
Yeah, and for reasons that are unclear, those with joint hypermobility, another big risk factor for both MECFS and long COVID, those patients are much more likely to have mast cell activation. That's
Oh,
a really important biological question for us to answer. Why are they connected? Why are they so commonly seen? And again, this is what I mean by non-random associations of these illnesses. People don't come in saying that their hair feels like it's on fire. They have lightheadedness, brain fog, exercise intolerance. The consistency of the symptoms is really difficult to miss.
Here, here. Well, on that, I'm going to leave you with one final question because we're
Okay.
almost out of time. The last question is there an audiobook available, audiobook version of your book available?
I don't think there is. I think there's like a Kindle or, an ebook. There's a paperback that I think is pretty reasonably priced at like $22.95, and then there's a hardcover book. I haven't talked to the Hopkins University Press about an audiobook, but that might be something to think about for later.
Folks are interested. We've got questions coming in about it. So with that, I unfortunately, because we're at time, I hate to do it, but I'm going to have to wrap up our conversation with Dr. Rowe. This has been such an amazing chat. Thank you for answering some of my questions, and thank you for answering questions from our audience. We didn't get to everybody's questions. We'll try to do a follow-up if we can to get some of those questions we didn't answer. But thank you all for joining us. Our next webinar is the first installment of our 4-part series on severe ME, which will be co-hosted with our friends at Bateman Horne Center. So I hope for those who are available and interested in joining us in our next webinar series, which is Severe MECFS, Care, Rights, and Research, a webinar series. Our first part is on caregiving, which will take place on October 9th at 10 a.m. Pacific time, 1 p.m. Eastern time. The registration link should be popping up in the chat for anybody interested in that webinar. And you can register for one or more of that series at that webinar link. And with that, I'll just say that if you'd like to see more of our educational webinars or support our research efforts or our advocacy efforts, please consider making a gift to Solve ME today. Attendees of today's event will receive an email link with the recording of today's session. For those of you who are interested in the recorded copy of this, it'll be available on our social media and our YouTube accounts. And last but not least, after this event ends, you'll receive a brief survey that'll appear on your screen. Please take a moment to share your feedback with us. We really care about improving, and your comments help us do that. So with that, many, many, many thanks, Dr. Rowe. Thank you for everything you've done for our patients, for our community, for both my family and many other families like mine. And thank you to everyone who attended today. We will be back in a few weeks with our next webinar, but until then, stay safe, rest well, and we'll see you through our channels. Take care, everyone.
Thank you.